All right, welcome to our Q&A, June 3rd. Over to you, Simon.
Okay, so questions for today. At what point do you start straightening out the upper and lower cat wire loops? Soon after expansion, at any point towards end of expansion. Find it's very difficult to grip and bend out the smaller lower cat wire loops. So the goal of managing the incisors with the cat wire is to make sure that you have ideally both of the wires touching as many incisors as possible. Normally, each wire should touch 3 incisors. And the lateral, the central, and central, lateral, central, and central. So the nature of the wire is that it comes out of the acrylic and then curves out and touches the incisors. So theoretically, you'll get 3 of the the distal teeth in contact. When you expand, you separate the 2 halves of the appliance and you effectively move the wire towards one side. So that 3-tooth contact eventually just becomes contacting only the 2 centrals. So as you expand, the end of the wire, which was contacting the lateral, is being separated and moving proximally away from the most distal tooth, and you end up with the end no longer in contact with the lateral. So the cat wire loops effectively is banking wire. All right, so we're storing excessive wire in the form of a curved loop for future use. When the goal is to make sure that the end of the cat wire touches the lateral and central at least, then as the wire is moved away from the lateral, once you get to a point where the wire no longer really engages the lateral, is when you unravel the loop so that you return the end of the wire into contact with the lateral. Now, I request a full loop, all right, so it curves back because I like to have full control and I have extra wire so that I can unravel it. I found teaching my students that very few of you have the dexterity or the skill to unravel a fully curved end loop of wire. So in recent years, I have recommended that you guys don't have the lab make a full curved loop, but just the semicircle curvature. All right, so it looks like a J, or it looks like more of a J, right, rather than a P, if that makes any sense, right? My appliances come back looking like Ps, letter P, where it curves all the way back, whereas I've recommended your appliances look more like Js. Why do I recommend that? Even though it's less wire to work with, it's obviously easier to get your bird beak into a J end rather than a P end. When you guys develop sufficient skills to unravel wire, then by all means have the extra wire built in. But if you're still getting appliances back with a full loop, like looking like a P, then I recommend that you don't have that and ask them or design an appliance that looks more like a little J. so that you can more easily engage the bird beak into the curved loop and unravel that. Prior to unraveling, whether it's the J or the P, as you expand in the lower appliance, you'll find that the end of the cat wire starts to dig into the acrylic of the appliance. So throughout each visit, as you see the end start to drag against the acrylic, I recommend that you grind away that acrylic. So systematically, each visit or every other visit, you're grinding away acrylic, and then once the end of the wire moves away from the lateral, then you start unraveling. So if you combine systematically relieving the acrylic away from the wire and utilizing a J curvature on the cat wire rather than a P curvature on the cat wire, then you will find it a lot easier to unravel. You also need to make sure that the pliers you have a fine enough end on the bird beak that you can get the bird beak end through the curvature so that you can unravel it. Okay. Next question. When fabricating an active retainer, if you still need to slightly procline the upper anteriors, do you generally fabricate retainer with both labial bow wires and lingual cat wires? So there's two types of retainers that might be active. One is in a younger patient where you have stable second primary molars, the E's are still solid, in which case you're clasping the E's, and it is effectively a stage 1 appliance without the screw. The second appliance is in older patients where you're changing over the primary molars, and instead you are clasping the 6-year-old molar and you're using a combined labial bow and cat wire to grip the incisors. In the younger patient, where you're clasping the E's, you don't need a labial bow because you have resistance point and retention sufficiently you have sufficient retention of the appliance with clasping the E's. You would use a labial bow if you wanted to tidy up any inappropriate rotations. But generally, you would just have the cat wires and the clasping the E's and the rest on the 6s. So you would advance the cat wires or intrude the cat wires as if you would in a stage 1 appliance. In the older patient, where the primary molars are exfoliating or exfoliated, you are clasping the 6-year-old molars and you are effectively clasping the permanent incisors with the combined cat wire and half labial bows. In those circumstances, advancing or proclining the incisors is done differently. In younger patients, you just intrude advance the cat wire as you would normally do so in your normal active treatment. In older patients with the changeover of primary molars, you are using what we call a stage 2 appliance. Clasping the 6s and you're clasping the centrals. When you're clasping the centrals and the 6s, you can't move the centrals or the 6s or you lose your retention. So my approach is you have to break the movement of the incisors into 2 halves. You will hold one side and activate the other side. So for example, the upper left, central and lateral, you are going to hold stationary. So the cat wire and the labial bow is not adjusted for anything other than passive hold. And then the right side, what you do is you release the half bow and you activate the cat wire just on the right, central and lateral. Once you've tipped them forward a little bit, then you engage that side passively to hold as your retention, anterior retention with the labial bow and the cat wire. And then you do the other side. So you release the half bow on the other side, and then you activate the cat wire. This is not an easy technique. All right, you have to have really strong wire bending skills so that you can engage with good retention in a triangular form with just 2 of the 4 incisors. Most of you will not have the skill sets to do this. Right? But if you work and practice and be diligent with your technique, then you will eventually develop sufficient skill sets to stabilize 2 of the incisors in retention with the labial bow and the cat wire, and then still differentially activate 2 of the incisors on the other side by releasing the bow and activating the cat wire. Next question. My 9-year-old patient had her x-rays taken a year ago, but mum is now eager for treatment. Do I need to have x-rays again? I do want to expose her to x-rays as she's young and has many. I do not want to expose her again. There are some changes, especially the Cs. So generally, anything under 2 years of the x-rays are still valid unless it's something that you specifically want to assess. Right? So if it's taken a year ago, then normally no, I don't retake them. If it's 2 years, then it depends on what you're trying to assess. So will you need a new lateral ceph? Probably not. Will you need a new pano? Possibly yes. So 1 year, probably neither. 2 years, definitely a pano, maybe another ceph. It just depends. Do remember a pano has significantly more radiation than a ceph. A ceph actually has a very low dose because it's a much faster image. A pano actually runs around the gamut of the head, whereas the lateral ceph is like a BA, just a large view. But yeah, if you're trying to determine how much life you have left in your primary dentition, or where permanent teeth have kind of wandered off in the scheme of growth and development, then definitely an OPG might be considered at the 18-month or 2-year mark. But at 12 months, I can estimate without needing to retake. Okay, so a year ago she would have been 8. There would be not a lot of change between 8 and 9. Next question. As there is a difference between functional posture relating to space between upper and lower teeth. Sorry, I don't quite I'm going to read the whole question and try to make sense of it. I don't quite understand it. As there is a difference between functional and posture relating to space between upper and lower teeth, does it mean if we use enough tongue pressure to palate to support mandible space about 1 mil, chewing muscles would be related. I actually have no idea what that question means. If you want me to answer it, can you reword it so that it makes it a little bit more sense? As
Chang,
it
can you?
reads,
Yeah, Dr. Chang is on the. Can you send it to us, please,
yeah,
in the
that
chat?
question actually
And
I can't
yeah, and to
see.
make it easy, everyone, when you're submitting questions via email, run it through ChatGPT, the Grammarly, something to clean up the grammar and the spelling for us, and that'll make life a lot easier. We can get through more questions. So just skip it for now and just go to the next question. Thanks.
Many patients have very tense masseters that are unable to open wide. Their tongue lying low, but in the TMD splint, the minimum space is 2 mils to stretch the chewing muscles. If it's for 3 months, will the chewing muscles, especially masseters, be relaxed after that? So I tend not to treat children with TMD splints. So historically, from in my practice, I've only ever treated adults with splint therapy. I don't often find that too many of them have, I'm assuming, the trismus issues. So trismus is a real problem for many patients, but I don't usually find trismus to be a problem with children. The only time trismus tends to be a problem is if they have a degenerative joint disease, so juvenile temporal mandibular joint breakdown, and it's not very common. Can children have very tight masseters and don't have capacity to open big? Sure, but usually still I found not to a level that I need splint therapy. So the most common reason for trismus for older patients is disc displacement, so that they end up with a locked close, and that's where splint therapy is used to decompress the joints and unlock the disc. So normally I'll use a pivot splint in adults who have a trismus because of joint displacement. But it takes a long time for the distal ligaments, the the retrodiscal capsule ligaments, to stretch out so much that the disc slips out of its position. So I usually don't find I have to worry about that in children. But yes, absolutely, in older patients, a pivot splint works really, really well. If there's a chronic, if there's an acute, usually it's anterior displacement of the disc. The pivot splint protocol allows the joint to be decompressed, and usually the disc slips back into place. Traditional splints don't work that well to decompress, don't work that well to unlock trismus, because you actually need to pivot the condyle out of its compression and free up the disc to be able to slip back into place. So yeah, if you're interested in that for older patients, then to search on pivot splints. The very easy, simple, effective protocol that has good literature-based evidence. Next question. I'm finding I have cases going well after 6 to 7 months. Parents no longer check the appliance and I need to refit the appliance. Consider adding a refit fee after maybe 6 weeks of initial start of the case. What are your thoughts on parent accountability and possible refit fee? So one of the things that we have to manage with these protocols is accountability. So there are 4 parties involved in any lab-based treatment. Okay? So any form of dentistry, there's no real getting away from accountability when you are dealing with a laboratory-based dental process. So you have a patient, you have appliances, you have the clinician, you have the parents, and you have the lab technicians. Right? So they're the parties involved. The warrantying of the appliances is responsibility of all parties. Right? The clinician has a responsibility, the laboratory has a responsibility, the patient has a responsibility, the parents have a responsibility. When we follow the protocols precisely, then appliances that stop fitting or fail to or break are the responsibility of the clinician. Right? So if we follow the protocols precisely, then normal wear and tear is something that we eat as clinicians. So we have to factor in that these appliances don't last forever. They're designed to be serviceable for about 6 to 9 months. So if we get 6 to 9 months out of the appliance, then when it fails, we eat the costs of the repair, the replacement. That's just factored into your laboratory fee for the procedure. Now, if the appliance fails earlier than that, stops fitting, then we have to figure out whose fault. If we didn't instruct the lab or didn't instruct the parents or the child correctly, then again, we eat the costs because it's up to us to make sure everyone follows the rules that I've set, my rules, right? Simon's rules, Simon says, because I've worked out a good protocol that allows us to have the appliance be serviceable for that 6 to 9 months. What's the protocol? Well, the protocol is we fit the appliance from patient left to right, left clip, left plastic, right clip, plastic, plastic, plastic is the protocol. We only ever use fingers and thumbs. All right, so that's the insert technique. Removal is from the right side out. We grip the clasp with the fingernail or thumbnail, and we push or pull to release it. Okay, so that's the child's responsibility. To follow the clinician's instructions. And our goal is it's worn full time other than removed twice a day for cleaning and for activation. When we follow that protocol, then we should get 6 to 8 to 9 to 12 months of service out of that appliance, depending on whether it's an active appliance or a passive appliance. If the child doesn't follow that protocol, but instead flicks it out with their tongue and crunches it home with their teeth, throws it in, presses down both sides symmetrically instead of in a seesaw action, then the appliance won't last as long and the fit won't be as good. And so that now becomes the child's responsibility and by default, the parent's responsibility for not policing the child. So if it fails earlier than that, then that's what we call a non-functional breakage. And yes, you can charge a fee for that, whatever fee you have. I have in my treatment plan set fees. All right, yeah. It's usually around 250 for a repair and 600 for a replace. So these are what we call non-functional breakages, and if the child doesn't follow the procedure and the parent doesn't police the child, then failures for fit, failures for appliance breakages are incurred. Now, does that happen instantaneously? No, it happens over many months. Right? So each time we see them, we get warning signs of non-compliance. We see the clasps are bent, squashed arms. We see that the plate is loose. We see that the child flicks the plate out with their tongue. We see when we ask them to put the plate back in that they don't follow the protocols. So you usually have many opportunities to warn the child and the parents that they're not following the protocols and that if they break it by not following the protocol or they delay treatment by not following the protocol, then there'll be a fee associated with that. If the appliance breaks very quickly, like within the first month, then that might be a polishing, over polishing error or a poor weld quality error from the lab. And A Point Enrico usually will warranty appliances if they fail within the first month or so. So that's generally a lab failure. A lab failure is something that happens within the first 30 odd days. If the appliance breaks because we're clumsy or heavy-handedness, then you know that you've done the wrong thing and so you eat it. If the appliance fails for no specific reason in the first 30 days, then take some photos and then send them off to the lab and discuss whether they think it's a warranty issue or not. When we aren't following the procedures and we have given ample verbal warning to the parents and the child, then they are prepared to compensate you for your additional lab bills and additional lab fees. If they've done what you've asked them and it's just wear and tear, then that's just part of the cost of doing business for you. So we state up front in our written contract that if we break protocols and appliances don't last or treatment is extended, then you warn them up front in the written contract what those fees will be. You will always have ample opportunity to warn parents, warn patients of them not following your protocols and the consequences of that. And if that continues and you have a failure on their part, then you have every right to ask them for the additional fee. Okay, so what is the protocol that ensures the expansion process is correct? We have 3 rules that must be kept before we do any expanding of the screws. We must have a retentive appliance. We must be eating with the appliance and effectively wearing it full time. And there must be no pain reported from the child. So those three rules apply prior to every activation of the screw. So again, it's up to you as the clinician to remind the parents to check with the child that the plate is retentive, that they are in fact wearing it full time, including meals, and that there is no pain associated with the plate. All right. Each night before expanding the screw, they have to run through that checklist. Right? If they fail to do that, then the expansion will not run according to my expected timeline. If they fail to do that checklist because you didn't tell them to, then it's your fault as the clinician, and any issues you eat yourself. If you have told them and they have forgotten, then again, you have ample opportunities to warn them of the procedure error. Because every time they come back with the problem from expanding or plates not fitting, you run through the checklist. Are you remembering to tell them not to flick the plate out? And are you checking that they're putting it in fingers and thumbs in the right way? Are you remembering to confirm that the plate is nice and tight, that they're eating with it, wearing it full time, and there's no pain and discomfort? Every single night, this is checked. Right? Every day we recheck this. Every day we recheck the process, the protocols, the instructions that you gave them. It's not just you tell them once and then they do it for the first week and then don't worry about it. It's like every single day they recheck. Right? So pilots run through a checklist to make sure their plane is safe, ready for flying every time before they take a flight. It's not just they do it once a year and then hop on the plane anytime they like. Right? We tend to be very lax when driving cars. Right? We take the cars in for a service, everything is checked once a year, and then we drive. But some of us don't take our cars in for services every 6 months or every 12 months. Some of us wait until the car dies before we take it in. Right? None of us, theoretically, before we take a car out every single time, what should we be doing? We should check that the tires are correctly aired. We should check that we have fuel in the petrol tank. We should check that the brakes work, the lights work, the brake lights work. All right. We theoretically should check this every single time before we drive our car, yes? All right? But we don't. And when we don't follow these protocols, we're more likely to have problems. Parents with the children's protocols will be the same. It's up to you to be as strict on them as if they were flying a plane, rather than be as slack on them driving a rental car. Okay. Next question. I'm still a little bit unsure about phase 0. When is the best time to start? Phase 0, I don't understand. I've never used the term phase 0, so I don't actually know what that means. Why erupting molars indicates we should wait until inclusion before starting phase 1. What happens if we have an erupting lower incisor molar seems a few months away from erupting? Better to start quickly or wait to start phase 1? Thank you. So we tend to have a very difficult, busy time for treatment. When is the busy time for treatment? When there's a lot of teeth changing over. It's really, really difficult to start anything. Typically, 6-year-old molars erupting and primary molars exfoliating. Right? They're the two time points where it's really, really difficult to start in. 6-year-old molars generally erupt around 6, and primary molars tend to exfoliate around 11. So normally at 6 or 11, we don't start any treatment because you're just working with a fluctuation of dental activity. That's all it is. Can you start treatment during that period? Well, yes. Is it infinitely more difficult to manage because of the fluctuations? Yes. That's all it is. If you have the skill sets to manage erupting teeth, adjust acrylic to guide them as they move into place, by all means, start while the molars are erupting. If you don't have that skill set, then wait until the molars have socked in so that you have one less variable to deal with. And that's all it is. My general rule is don't treat at 6, don't treat at 11. Uh, but it doesn't mean that you can't. The higher your skill sets, the more your scope of range for starting treatment and the more difficult cases you can manage. As someone who doesn't have the experience to manage erupting molars, don't start while teeth are coming through at the back. If the molars are many months away, then by all means you can start. But you've got to make sure that you encapsulate those teeth in your expansion phase, which means that you have to have extension of the acrylic to include the yet to erupt molars. And you have to have the capacity to adjust away acrylic when those new molars come through so that it's perfectly guiding those molars so that it doesn't stop them from erupting and it doesn't push them off into a weird direction. All right, that requires really high level of observation skills and understanding of how much to grind away and how much you can guide, how much to leave in place to guide the molars in their eruption phase. When you feel like you have that skill set, you can treat it at any time. When you don't have that skill set, generally don't treat as the 6-year-old molars are erupting. That's all it is. Next question. When expanding the maxilla, we use acrylic bite ramps to prevent a scissors bite, since upper expansion occurs faster than lower expansion. Yes. However, if the target intermolar width in the maxilla exceeds what can be achieved by uprighting the lower molars and flattening the curve of Wilson, how should this discrepancy be managed? Specifically, should the maxilla be allowed to partially relapse until it settles into a harmonious occlusion with the mandible, even if the final upper width falls short of the original treatment column? Yes. So if you miscalculate your expansion ratio, right, and you end up with an upper that's too wide in comparison to the lower, then you're going to need to correct this, right? You have to, right? If you're expanding away and you haven't paid attention to the intermolar width, or you haven't paid attention to the size of the teeth. So your ultimate expansion dimension depends on in combination of the expected width and the individual width. Okay? The expected width on average is intermolar width of 37, 38 mils. Right? The reality is some people have big teeth and you're going to need 40, 41 mils, and other people have teeny tiny teeth and you don't need much more than 36, 35. So there's a little variable depending on this individual patient. So you've got to be mindful of that individual variation and not just blindly turn until you have 37, 38 mils. All right, when you get to 35, you've got to do a mental check and calculation. Have we got teeny tiny teeth? In which case, we're probably getting close to stopping, 35, 36. I've got enormous teeth and, we're not stopping until we hit 40 or whatever it is. If you've miscalculated and you end up with an upper that's far wider than the lower, then you have to make a decision. Are you going to allow passive relapse or are you going to actively compress. If you still have some cuspal contact, then one way of allowing relapse to occur is just leave the top plate out and let it relapse. The relapse tends to return in the direction of the expansion. If, however, you've gone so far that if you take the top plate out, you'll end up locked into a scissors relationship, then you've got to actually rewind the plate. Now, rewinding is not a simple process. You can't just rewind it in the same way that you wound it open. So rewinding I do occasionally because of miscalculations, and I tend to limit it to 2 half turns a week. All right, so I'll rewind the plate. I'll get the parents to wind it backwards, but instead of 7 days a week, it's just twice a week. So Monday, Friday, Sunday, Wednesday, something like that. All right, so you just get them to rewind it backwards twice a week until you get back to the dimension they want. Doesn't always work, but it's reasonably accurate and predictable if you limit it to twice a week rewind. So long as you haven't done a really stupid thing and gone so far out that you're not going to be able to compress. So you've got to recheck the intermolar width on a regular basis. Every time they come in, you should be checking everything. All right, last question. Is there a difference between muscle activity during oral posture and oral function, especially during chewing? Does it mean if patients can use enough tongue pressure on the palate, the chewing muscle should be relaxed? Many patients have tight masseters and are unable to open wide, their tongues are like low. So obviously there's a difference between muscle activity and oral posture and oral function. In oral function, the muscles are active. In oral posture, the muscles should be passive. All right. In correct oral posture, the muscles should be effectively passive, and it's a vacuum seal in the mouth that is holding everything together. All right, that's correct oral posture. In learning correct oral posture, you have to activate the masseters to close the mouth, and they will have to actively hold that position because they don't have the capacity for a vacuum seal or tongue to palate holding it in what we call a physiologic protective rest position. So initially, there have to be slightly active masseter temporalis muscles to artificially hold teeth together. But in the long term, when you have achieved correct oral posture, then the muscles will definitely relax because it should be passive and held only by vacuum seal. Right? So when you're stimulating patients to artificially keep their mouth shut, then yes, there'll be tight masseters because their tongue is low-lying and not creating a vacuum seal. So you're using masseters for a closed position rather than relaxing the masseters and using vacuum seal of the tongue suction to the palate to hold the mouth closed. So absolutely. All right, fantastic. That's the end of today's session.
Okay. All right. Thanks, everyone.